weighing. And then I got very good responses from the last lecture. And then because he tried to cover many aspects of climate change and health. So that was quite good response from other area other than public health also. So and then I think the public health is getting more and more attention from the society, especially this crisis.
Yes.
But I personally, I think COVID is not the only problem. We have to think about the wider range of health problems, I think. So that is another issue, and I probably think that in Japan and Korea, the total mortality, I mean expected mortality, the gap between expected and observed would have been, I think, I mean, the beneficial. We see more. We see other beneficial effects from the hygiene or other infectious diseases. So I'm very interested in calculating the expected deaths overall, but the mortality data is not available yet. So this is very good. I mean, in terms of research, it's a very good time for us to investigate. I mean, having many questions.
That's right.
Yeah. So.
Right.
That is our challenge for few more years, I guess.
2 more years.
Okay, 1 minute. So how's the school in Tokyo? So all these classes are online or?
Yeah, still, actually, the many universities are, coming back to the, lecture in person, schools. But University of Tokyo is still very cautious, to come back to the, the classroom. So, most of the lecture will be still on Zoom, at least in my school. Yeah. And also the graduate school levels.
Right. So the most of the cases are reported in metropolitan Seoul area. I think it's similar to Japan in Tokyo area. So in that term, it's already become a rural problem, not urban problem. I mean, urban problem. So the patterns are quite different from the previous infectious diseases also. So I think urban and rural comparison would be another.
I see. Right. Another reason to keep the online lecture is that our School of International Health, some of the international students cannot,
okay, all right, okay.
To Japan, so still they are staying at their own country. So that's another reason to keep online.
So we have a partial audience in the Zoom system, and then a partial audience at the YouTube also.
I see.
And then if some audience in YouTube, if they have questions, they will use the text questions. And then you will see the questions through the chatting box over there.
Okay.
So after you talk, you may want to open the chatting box at the Zoom system so that you can understand the questions through YouTube. Okay, so so it's already time passes. So hello everyone. Welcome to our seminar series. So today's topic is climate crisis, disasters, disease pandemics, and health disasters. And I'm very happy to introduce and privileged to introduce today's speaker, Professor Masahiro Hashizume at the University of Tokyo School of International Health. His background is a medical doctor and environmental epidemiologist with many interest in the environment and health. He is currently a lead author of IPCC AR6 and then has many experience of climate and environmental issues in this area. Personally, he has been a good friend of mine for how many years? More than 15 years. And then we traveled many places together, investigating or advising the adaptation of climate change and health issues. So I asked him to introduce the COVID-19 cases, COVID-19 situation in Japan, so that we may learn each other to cope with this crisis related to the climate crisis also. So we'd like to start his lecture. So please give him a warm welcome through internet. Professor Hashizume, it's all yours. Thank you.
Thank you very much, Professor Kim. I'm very happy to see you all in this, lecture. As Professor Kim introduced, my major is the environmental epidemiology, especially specifically in the health impacts of climate change. As far as I know, Professor Andy Haynes has talked about, this issue in the last lecture. So today, I'd like to talk about the kind of the health impacts of COVID-19, specifically in Japan. But I'm not, how to say, the expert of the infectious disease, or preventive medicine. So my focus will not be a kind of, how to prevent of the, COVID-19 infection, but more on the, total impacts on our society in terms of the, all-cause mortality. Okay, so I'd like to share my slide. Can you see my slide?
Yes.
Okay. So the subtitle of my talk is that direct and indirect health impacts of COVID-19. Okay. Okay, so this is just an overview of the number of the cases and also the geographic distribution of the COVID-19 cases. And up to yesterday, there have been 132 million cases of COVID-19 all over the world, including, I think, 2.8 million deaths. Right. Then this is the situation in Japan. Number of time series data of the number of new COVID-19 cases in Japan, categorized by age groups. So first, this is actually weekly number of new cases. So first case was reported in January 16 in Japan. And this graph shows the number of weekly number of cases since the end of March 2020. So the state of emergency was issued in the beginning of April till the end of May last year. Then this first wave was, how to say, diminished during the first state of emergency. But after that, in the middle of June, the cross-prefecture travel restrictions requested by the government was lifted up due to the the improved number of cases. But after that, the population mobility was increased actually. Then the number of new cases was increasing again, which you can see a second wave here. Then people became aware about the increased trend. Then after that, from the middle of August, the number is decreasing. But people at the same time worried about economic activities in Japan. Probably the situation similar in Korea. Then government started the campaign named Go to Travel, which encouraged the people to travel around the Japan. So government actually supported certain proportion of the the expenditure for traveling. Okay, that's the campaign. But after this campaign started in the middle of the July, in September, the number of cases are sharply increased up to the beginning of this year, January. The third wave, the size of third wave was much bigger than the previous, two waves. Then the second state of emergency was issued by the government in the beginning of January up to 21st of March. And during state of emergency, the mobility, the population movement actually decreased because of people's, higher awareness. So number is decreased after, after that. But now we are facing that kind of increasing trend again. It could be a starting point of fourth wave, especially in Osaka area, the western part of Japan. So as you can see, many certain amount of proportions are the younger generations, 20 to less than 60 years old. Okay. So this is overall time trend of the COVID-19 cases in Japan. Then this is the number of time trend of number of PCR examinations. Initially in Japan, probably in contrast to Korea, the number of PCR examinations was not so large. Actually, the government initially saved, tried to save the number of PCR examinations. But it was criticized actually. Then number of exams are increasing. So almost similar pattern with the number of cases, the first wave and the second wave and third waves actually, and the proportion of PCR positives actually also up and down the first, second, and third wave. but the proportion is rarely over 10%. It's almost around a few percent or less than 10%. Okay. These three graphs are about hospital admission and severe cases, proportion of bed occupancy, and the number of prevalent cases. So hospital admissions, this is also the weekly number of hospital admission and severe cases due to COVID-19. So, again, there are three waves so far. In April and in August, and from November to January last year. And number of severe cases, also the similar pattern with the number of hospital admissions. The critical thing is that how many beds or how much proportion of the special beds for COVID-19 are occupied actually by the patient. So there are also three waves so far, and the hospital admissions, bed occupancy due to the hospital admissions was high in the beginning, between 30 to 40% of the bed was occupied by the patient. Then with the decreasing first waves, it's improved, but with the second wave, again, increased. And then in the third wave, with the peak in January, the highest peak was almost 50 to 60% of the beds was occupied by the hospital admissions. The the bed occupancy by the severe cases are also similar patterns. Right. So the prevalent cases, not all the people infected with COVID-19 admitted to the hospital. Non-severe cases, moderate to mild cases, are recommended to stay at home or to stay at hotel. I mean the designated hotel, especially the government actually prepared or secured the number of rooms in the hotel to encourage the people infected with the SARS coronavirus staying at hotel. Okay. So nowadays, certain amount of cases are staying at home or hotel. Yeah. And almost the same number was the number of hospital admissions. That's the overall situation. Right. So actually, I have been involved in the project by the government, Ministry of Health and Welfare, Labor and Welfare, to estimate the excess deaths or excess mortality during the COVID-19 pandemic period, which means from the beginning of the 2020. Actually, excess deaths or excess mortality is a kind of indicator to measure or to estimate the overall impact due to the COVID-19 pandemic. Overall impact means there, in addition to the kind of direct impact of COVID-19, which means indicated by the number of COVID-19 cases or number of deaths due to COVID-19, but also there is a indirect effect or indirect impact due to the COVID-19 pandemic. So excess deaths can be calculated by using the number of death cases in the past, in the previous years, actually, by using the statistical methods, in general, time series, models. Then by using the previous number of deaths in the previous years, we can predict the expected number of deaths in 2020 after the COVID-19 pandemic. Then by subtracting the expected number of cases from observed number of cases, we can calculate excess number of deaths. Okay. So for example, for this graph, the blue bar shows the observed number of deaths. Actually, this is weekly number of observed deaths. So in 2017, 18, 19, and 20. Right. And this is the data, real data from Tokyo. So every year, there's a peak of number of deaths in winter and trough in summer period. It's common, I think, in many cities or in many countries in temperate climates. Right. Then by using assuming that this pattern, you can see the regular seasonal patterns. So we can assume that this pattern can be continued in 2020, assuming that there is no COVID-19 pandemic. Okay. Of course, there should be some statistical uncertainty for this estimate. So the green line shows the upper limit of the 95% prediction interval, or almost similar with confidence interval. And the black line shows the lower limit of the 95% confidence limit. So excess deaths can be calculated. For example, this week we observed more than 2,500 deaths. And this number minus, the predicted or expected number, which is the upper bound of here, the green line shows. This will be the excess deaths, specifically for this week. Okay. Yeah. This is just a general concept of excess deaths. This is the example of United States, presented in the website of CDC. So 2020, January around here. And this, blue bar shows observed number of deaths. And the orange line shows the upper, threshold of the excess deaths. Then after around April last year, you can see the excess number of deaths beyond or above the expected upper bound of expected death. So you can see the excess deaths constantly after April 2020, although it's reducing after the January 2021 this year. Okay. Then this yellow green bar shows the previous number of deaths from all causes, but excluding COVID-19. Okay. Then this blue bar on top shows the number of deaths from all causes, but including COVID-19. Okay. So the blue bar actually can be interpreted as the expected number of COVID-19 cases. Okay, so this is a kind of direct effect. This is an example from Europe. This is a website called Euromomo. They are collecting weekly number of all-cause deaths every week, and this data shows data from 26 countries, Austria, Belgium, Cyprus, up to the UK, right? And this is the weekly, excess deaths, number of excess deaths from beginning of 2020. Actually, 2020 shows these blue lines. So around 10 to 20 weeks. So it should be around March, April, May. There is a kind of first wave of the number of excess deaths, more than 30,000 in the specific weeks, around 15 weeks. Then it reduced, but again, at the end of the last year, excess deaths can be observed again in European countries. So another study, published in Nature Medicine, also calculated the excess deaths due to COVID-19 using all-cause mortality data in 21 industrialized countries. Sorry, it's very small, but these are the 21 countries, mainly from Europe. And they estimated, again, the estimated number of deaths and confidence intervals. So graph on right-hand side shows the excess number of deaths observed. Deaths minus expected deaths. Then their conclusion is that England and Wales and Spain experienced the largest effect, up to 100 excess deaths per 100,000 people in these countries, and it's equivalent to 37% relative increase in England and Wales, and 38% in Spain. This graph shows from the Wall Street Journal, so it's not from academic paper, but it's interesting. They compare the number of the excess deaths between 59 countries up to using the data up to January 2021. Okay, so the size of this half cycle shows the number of actual deaths. So this shaded area shows the number of COVID-19 deaths due to COVID-19. So it's indicating a direct effect, but the outside outer black area shows a kind of indirect deaths. So in total, it shows the excess deaths. So US has the largest excess deaths, among 59 countries. And certain amount of proportion of excess deaths is due to actually the COVID-19 death. The second was Mexico, followed by Brazil, Russia, Peru. For Russia, compared to US and Mexico, the proportion of deaths due to COVID-19 is smaller, right? Compared to the kind of deaths due to other reasons. In the UK here, Spain, right? And South Korea is here. I think the unique characteristics of South Korea is that the proportion of the COVID-19 deaths among total, excess deaths is small. So indirect impacts of COVID-19 are bigger than the direct, effect of COVID-19 cases. In total, up to January 2021, 2.8 million excess deaths was observed. And among 2.8 million, 2 million was the deaths due to COVID-19. So less than 2/3 has been attributed directly to COVID-19, and 821,000 deaths was kind of deaths due to indirect effect. These are the other countries, right? And interestingly, 9 countries show the negative excess deaths, which means number of deaths was reduced compared to previous years during the after COVID-19 pandemic, meaning total deaths fell below expected numbers despite the COVID-19 pandemic. And actually, Japan showed the largest number of the negative excess. That's quite interesting. So we still don't know what's the reason of the negative excess deaths or reduced mortality in Japan. That's a big question for us, and it's worth investigating detail. I have 2 hypotheses at this moment. This is again the excess deaths in Tokyo. So you can see the minus here. So the week with the this minus showed the negative excess deaths or death deficit. So you can see the deficit weeks with deficit deaths concentrated in the beginning of 2020. It's actually almost before the COVID-19 pandemic in Japan. So people's awareness are still not very high, up to March 2020. But number of deaths actually was reduced, compared to the previous years. This is because I think it's due to the lower number of influenza cases. Actually, for the winter, in the beginning of 2020, number of influenza cases was unusually, lower than the previous years. Actually, influenza cause actually pneumonia and other respiratory diseases, which could be fatal for, especially for elderly or older population. So that might be the reason the observed death deficit here. But we cannot explain death deficit after influenza season, like around June, July, or even the end of 2020. So these could be due to the public health interventions against COVID-19. So people's awareness for hygiene behaviors, wearing masks or prevent close contact with the other people, or hand washing behaviors could have contributed to prevent the infectious diseases in the population levels. So these two reasons might be contributing to the observed death deficit in 2020. By the way, you can observe excess deaths here in August here. I assume this is due to the heat wave observed in August. Last year in 2020, the temperature was unusually high in August. Then the number of ambulance transport due to heat stroke was high in these weeks. Then the number of deaths also increased. Yeah. So the heat-related illness, you understand, it's very sensitive to the the hot temperature. Okay, so we estimated by using the mortality data in the 5 previous years mortality data. We calculated the excess deaths for death deficit. So this is the relative risk. Relative risk 1 means no difference in the in the risk of death compared to previous 5 years, right? And here, January, this is we use the interrupted time series design. So January is set at 1, right? Then you can see the negative or the relative risk under 1, which means the protective throughout the year, almost. That means the risk of death was lower in the 2020 compared to the last before 2019. Both sexes, males and females, are all similar patterns, actually, right? By the way, this relative risk after adjusting for temperature and influenza. So this decreased number of deaths is not due to the influenza or the temperature, due to other reasons. And the lower graph shows the relative risks over time, from January to December last year, by the age groups. So black line shows all age groups, and you can see the younger generation group, less than 60, showed some excess, especially around November. But older generation has showed the kind of protective effect after COVID-19 pandemic, right? And in total, we estimated that excess deaths was minus 21,000, which means percent excess was minus 1.8%. But we still don't know why we observed negative say, protective impact of COVID-19 pandemic. So we calculated excess deaths due to the specific causes by neoplasm, which is mainly for cancer, or circulatory disease, respiratory disease, senility for older population. Okay, because these are the top 4, cause of death in Japan. Then, I'm sorry for Japanese slides. We estimated the total number of excess deaths for each year, 2017 till 2020, by these 4 causes, including all causes excluding COVID-19 deaths. So this is the total number of weekly excess deaths, right? So as you can see, the number of excess deaths, total number, cumulative number of excess deaths is almost same or similar in 2020 with the previous 3 years. Okay, of course, respiratory deaths, excess deaths looks a bit smaller than in 2019 or 18, but 2017, it's almost the same. Of course, there was no COVID-19 in 2017, right? Same for circulatory death, malignant neoplasm, senility. Okay, almost similar with previous years. So our conclusion is that there was no actually substantial excess deaths in Japan. And we separately calculated death deficit. I mean that cumulative weekly number of the death deficit. Then we observed a substantial increase in the death deficit due to respiratory death. And circulatory deaths also a bit, bigger than previous years. For malignant neoplasm, senility, it's almost the same with the previous years. So observed, death deficit can be, mainly due to respiratory deaths and circulatory deaths. We also investigated other causes. What could be, what factors contribute to the reduced, number of deaths in 2020? This is the result of the road injury deaths by using the police, data from police agency. So in 2020, compared to previous years, in some of the weeks after COVID-19 pandemic, the number of road injury deaths was significantly reduced, compared to last year's. Actually, there was a decreasing trend, almost a 2% decrease every year in Japan about road injury deaths. But still, after even adjusting for this, decreasing trend, we still observe some, reduced number of road injury deaths in all prefectures. And this is the result from 7 prefectures, relatively a bigger, population. Still, there are some, deficit of the road injury deaths in these prefectures. But number itself is not very big, actually. So that contribution of the by the road injury deaths to the overall observed death deficit might be small. What about suicide? This is monthly data of the suicide, right? So after 2020, after COVID-19 pandemic, actually in April, we observed reduced suicide, but after July, especially for women, we observed, excess number of suicide. It's very substantial here. But men, it's not very obvious. Only in October, there are some excess suicide. But women are continuously, indicating the excess suicide. So that's getting a big social problem. Probably not only in Japan, but I don't know, all over the world, including Korea. That could be due to domestic violence or other stressful life due to the unemployment after the economic recession, right? But still, we don't know the real reason for that. This is just the phenomenon of this suicide. A similar analysis has been done for healthcare access or hospital or clinic access itself. It's really not a direct health outcome, but after COVID-19 in Japan, we observed reduced number of healthcare access, especially in the beginning from March, April, May to June in the general hospital. For psychiatric hospital too, only in May to 2020. Right. I don't know. It's how it can be contributed to the observed death deficit. We also estimated ambulance transport due to heat illness, especially in summer, from July to September, because people tend to stay home and work at home. So our hypothesis was that the heat exposure might be reduced in this situation compared to the previous years. Then number of ambulance transport due to heat illness could be reduced. And another concern was that because most of the population in Japan wearing masks after state of emergency, that wearing masks actually will contribute to the heat stroke because lower ventilation rate due to the masks. So there could be some both negative and positive effects hypothesis there. Then we calculated excess number of ambulance transport for 2020, but actually the gray bar shows the observed ambulance transport. Then black dot line shows the expected number with the upper and lower limit. Then there was no substantial increase or decrease of ambulance transport. There was no significant difference for that. That was my our temporary conclusion for that. Right. So so there could be many hypotheses actually which factor contributed to the death deficit observed in Japan during the COVID-19 pandemic. Then we need some evidence actually. Also, environmental and social factors could have contributed to the COVID-19 incidents, as well as other health outcomes. So we need some evidence by analyzing epidemiological data or whatever. So from the beginning, some people are interested in the weather factors or climatic factors has some effect on COVID-19, incidents. And there has been many, studies has been done, to associate between the climatic factors and COVID-19 incidents. Actually, the World Meteorological Organization compiled the review report for the association between air quality, meteorological and air quality factors and COVID-19 incidents. And it's open to public, so if you're interested in, you can see the draft document from WMO website. So actually, in that report, some of the meteorological air quality factors like temperature, humidity, ultraviolet radiation, and air quality, which is air pollution, could influence on virus viability and host immunity. Host means population, people immunity, and human behavior. For example, viral surface proteins and lipid membranes could have influenced by the temperature and humidity, right? Viral genome, for example, also influenced by the temperature and also the ultraviolet radiation, right? So these atmospheric factors could have some effect on virus variability. Then will affect the transmissibility and incidence of the COVID-19 cases. For temperature, will have a influence on antiviral immune defense for host and the human being, or inflammatory responses, or vitamin D intake via UVB enhancement for the immune responses. Right. Human behaviors could be also affected by the temperature, humidity, or ultraviolet radiation. Right. Right. So these are the potential mechanisms how the meteorological and air quality factors could affect the COVID-19 incidence, but still hypothetical. Right. The summary of this report is that epidemiological studies of COVID-19 have offered mixed results. So some studies reported a positive association, for example, between temperature and COVID-19, but the others report a negative association, or some reports, reported no, significant association. So it's a mixed results still, right? And COVID-19 transmission dynamics appear to have been controlled primarily the government interventions, right? Non-pharmaceutical interventions, actually, rather than meteorological factors so far. And some evidence of the virus survives longer under cold, dry, and low ultraviolet radiation conditions, similar with other viral diseases like influenza or respiratory syncytial virus, which is more, let's say, epidemic in winter. And evidence that chronic and short-term exposure to air pollution actually exacerbates symptoms of COVID-19 and increase the mortality rates for some respiratory disease. That sounds very general, but that review report of WMO summarized these findings. Okay. So still, there is no clear conclusion for the relationship with meteorological factors or air quality. But after, we already experienced 1 year after pandemic, then there could be some seasonality of the COVID-19 cases. So this draft paper examined the seasonality in 2020, just 1 year, by the region, a geographical region, America, Europe, Africa, Asia, and Oceania. So the pattern is, might be not very, similar between the regions. Even in the regions from north to south. For America, the pattern is similar from North America to South America. There are two peaks. One is in around July and the other one in January, this 2021. For Europe, there's a single peak from north to south around December. Yeah. In Africa, in North Africa, there's only one peak in the end of last year, but other regions, there are two peaks. In Asia, from Central, East, West, South, and Southeast Asia, it's heterogeneous. Yeah. There are, in some regions, there are two peaks, but some, especially in East Asia, was a single big peak so far. In Oceania, it's also some single peak, but timing of the peak was various. So we don't know how the seasonality will be changing this year or following years, but the COVID-19 could be could show some regular seasonal patterns like influenza on the winter peak in the following years, but we still don't know how it will be changed. So we need to monitor on that. Okay. So another aspect of the COVID, indirect health impacts of COVID-19 is that health impacts through the reduced air pollution levels by the lockdown interventions. So this study estimated the reduced air pollution levels in China and Europe in March to May 2020. Okay. So blue area shows the estimated PM 2.5 concentrations are reduced compared to the previous years in Europe too. Because of the lockdowns, strict lockdown in China and some countries in Europe, the air pollution levels from the automobile or the factories, industrial, sectors are much reduced, especially in March, May, April, May. So then in China, from February to March, this red line shows the PM 2.5 levels in the previous years, 2016 to 19. But blue line shows estimated, PM 2.5 levels to 2020 after pandemic. Then on average, PM 2.5 levels are reduced almost 30% in 2020. Then of course, air pollution is not good for health. Actually, it's a lot of people are killed actually from the ambient air pollution. So the authors of this paper also estimated number of avoidable deaths or avoided deaths due to the improved air pollution levels, especially for PM 2.5. Then they their calculation is that 24,000 deaths was avoided due to the improved air pollution levels, right? At least in February and March. So this number, the avoided deaths, is much bigger actually than the number of deaths due to COVID-19 in China. Europe also air pollution levels, PM 2.5 levels are reduced, but smaller than in China, just 17% estimated. And over 2,000 avoided deaths are estimated, right? But the number of COVID-19 deaths are much bigger than this avoided deaths due to PM 2.5, right? So you understand that lockdown interventions led to substantial reduction in PM 2.5 concentration in China and Europe, and tens of thousands of premature deaths from air pollution were avoided, actually. So this study suggests that considerable improvements in air quality are achievable, actually, in both China and Europe, when strict emission control policies are adopted, right? Okay, so the kind of commentary published in BMJ in January this year, COVID-19 rehearsal to build a greener and healthier society, actually. So COVID-19 pandemic can be actually viewed as a natural experiment, showing that social change is possible with the rapid international action, priority setting, and the mobilization of the financial resources. So government lockdown policies reduced travel, industrial production, energy generation, which in turn decreased the greenhouse gas emissions that will cause climate change and the air pollutions. Actually, 7% reduction in global CO2 emissions are estimated in 2020. Right. So with a strict policy, how to say, with a strong policy leadership of the policy makers, we might be achieved to build greener and healthier society. So so COVID-19 could be a kind of trigger for to develop such a society, but we need to be very careful because after the global financial crisis in 2008 to 9, the CO2 emissions rapidly rebounded, mainly from large emission growth in emerging economies after the financial crisis, right? So the global community should learn from this COVID-19 event and design the recovery plans that protect vulnerable groups or mitigate climate change and reduce air pollution levels. So we now have to make use of this crisis and implement actions to protect people and also the environment and planet. Okay, that's my talk. And the slides which I showed in the previous slide, how to say, the time series of the number of deaths, can be available from this website. This is open just last week. then you can see the this number of excess deaths updated every month. So and also not only for the results, but data, raw data, are also downloadable from this website. So if you're interested in, you can also calculate. We also opened the R code, the statistical code to calculate the excess deaths. So if you're interested in, feel free to download our code and data and reproduce the output. Okay, thank you very much. If you have any questions, I'm happy to respond.
Yeah. Thank you, Professor Hashizume. This is wonderful and very insightful, as well as very practical, especially last slide. I think we can do similar things in Korea and in the view of public health, not medical view, but your insight is quite different from the traditional medicine, I think. So you provide us many insight, many, I mean, the research topics, I think. So very, very helpful for the students and public health researchers, I think. So I think we may take several questions from the audience. So if you have any questions, I think I expect many questions, but we have time limit. But as far as we can take, I encourage all the audience to have to give us some questions. Then the discussion will be very interesting, I think. So so far we haven't received any questions. I don't see. Yes, we have one person. Yeah, so you can go ahead using Zoom.
Yeah, thank you for your talk. And actually, I'm in Japan. Like, my name is Samuk Jung, and I'm majoring infectious disease modeling in Kyoto U. And actually, I would like to ask your opinion about the small number of excess deaths during the second and third wave in Japan. And I agree with your hypothesis because before April and in June, the number of cases were super small in Japan. But during the second and third wave, the number of daily reported cases were significantly higher than that of Korea, which might cause the kind of like really huge burden in hospital setting. So I'm just wondering why we had a really small number of excess deaths during second and third wave in Japan.
Yeah, that's really a good question, actually. We still don't know the reason why, even though the larger number of the cases, than in the first wave. Right. Right. But actually, the number of cases itself, actually, absolute number of the cases itself, actually the much smaller than in Europe or US, which show the a substantial number of excess deaths. So although the number itself within the country in the third wave, second or third wave, is bigger than the previous wave, but still the absolute number itself are relatively smaller, this might be contributing to actually to the not substantial number of excess deaths. But this does not explain the the reduced number of deaths, actually, or death deficit. So this is still the question unsolved. So I think there's a lot of opportunity to for the research. What kind of factors are contributing to the reduced number of deaths or death deficit, especially in Japan. Japan is quite unique, I think, as I shown you the previous slides. So if you have any hypothesis, that would be, I think, very helpful for everybody.
Actually, I don't have a clear hypothesis, but thank you for the answer. Thank you.
Yeah, yes. I think we are still in the middle of a crisis. So my question would be, your data didn't include the third wave in Japan after October, for example.
All right.
Right, for calculating excessive deaths.
Right.
And the third wave was the biggest. So if you include that, then you might have somewhat different conclusion, because you exclude the biggest event. So that looks like you are estimating the number of deaths a little bit lower.
Right.
Right. So that would be something I really like to see, if you can add more data.
Right.
All right.
That's true. That's a good point. Yes.
Yes. Yes. But the overall, the report of, I mean, you show the air pollution of comparing China and Italy, and then the pattern is similar overall. Only if we only focus on mortality, the Asian countries is not suffering. I mean, in countries a little bit beneficial in terms of mortality only, like Japan or China, but a huge mortality burden in the Western countries. So there is a big contrast between cultures, two cultures, I think.
Right.
So that would be another interesting topic for the future. But I think as time goes, this kind of contrast will become less and less. That's my thought.
Right.
So that comparing only 2020 or limited time period would be maybe a good idea to compare the societies, I think. But anyway, considering the only mortality, only COVID mortality, we need to overcome that view, including all the other aspects of mortality, like excessive deaths would be a good example. And I heard that one Korean researcher did the similar thing, and then the excessive mortality is almost zero, plus minus that effect, but found a few cause of deaths. I think it's cardiovascular and the respiratory disease. He found a little bit small, a little bit positive surplus of excessive deaths.
I see. Right.
So the pattern would be very similar, I think, compare. I mean, Korea and Japan, which is very different from, say, Western countries, I think. So that is, and I have, we have one question at the chatting box. So you may see the question. Let me repeat. Let me read the question. Thanks for the great lecture. I have one question for the website on excessive mortality. The last part. Is there any policy implication of feedback intervention from the result of excess deaths? That is the question.
Okay. Is there is there any policy implication of feedback intervention from the results of excessive? Okay, that's a really good good question. It's related with the purpose of calculating excess deaths. Right. Right. Actually, the initial motivation for the government to start this project estimating the excess deaths is that as I mentioned in the lecture, in the beginning, the number of PCR exam was quite low in Japan. Then the government was criticized. Why not increasing the number of exams? Because of the small number of exams, there could be some hidden cases of the COVID-19. So the number of presented by the government could be much smaller than the real number of COVID-19. That was the initial criticism. Then the government tried to show the kind of real impact, public health impact of COVID-19 by showing the excess mortality. Actually, this might not be a actual answer to that question, right? But anyway, I think calculating excess mortality would be could be a kind of retrospectively monitor or evaluate the public health intervention which has implemented in the past.
Yes, the policy related question is always difficult, but let's go to the next comment or questions. He said that in Korean case, death data is not available, but we can do something using the insurance data. And then in Korea, PM2.5 was reduced during the COVID crisis. And how about Japan? Do you have information decrease of PM in Japan also?
Still, I don't know.
You don't know.
I haven't looked at really the air pollution levels after that.
My hypothesis is that in China the reduction was a little bit big, and that reduction in Korea is a little bit smaller compared to Chinese reduction. And Japan would the number would be even smaller. That's my imagination, that we need to check. But in Korea, what I know is the ozone was ozone level went up actually a little bit. So we need a balance. Think about the effect of PM and ozone. Usually they have negative association. So that is also very difficult question so far. So we need to think more. Right. But anyway, the speaker introduced many insight overall or bigger thoughts on the society, impact of society, and other economists may argue that health is not everything. So how about considering economical impact overall? Then you may say that deaths, the smaller excessive death counts or death deficit in excessive deaths would mean nothing if you consider economical impact or recess. Right. So what is your comments on response?
It's also a difficult question to answer, but yeah, actually, there is a kind of criticism. Some people criticize against the how to say, infectious disease prevention, measures implemented by the government. For example, many restaurants are forced to close at 8 p.m. At night, not later than 8 p.m. Then their income was, much reduced. Although the government supported their, the income salary, but many also it's also true that many people how to say unemployed because of the economic recessions. So some people criticize that it's too much. Public health intervention, how to say, should take a balance with the economic activities, actually. So we actually showed that, the reduced number of deaths that could be utilized by that, critical people. As an evidence of the too much public health interventions. But we need to be careful how to interpret that results.
Right.
Yeah, but it's also true that if economic situation become worse, it will be also influencing the health status. How to say, consequently, but with some time lag. So actually, we need to some of more data. I think, as you mentioned, only the short term period of the data, we cannot conclude any definitive things.
All right. And last question, my personal question, the high suicide rate for young women was pretty impressive, and we observed a similar phenomena in Korea also. But I was told that in Japan last year, a young celebrity suicided, and that has a huge impact on especially for the woman of similar age, feel the same way. That was one of the reasons of the high suicide rate in Japan for young women. So what do you think the effect will be? If that's the true, my hypothesis is that if we subtract the effect of Japan to Korea, then we may be able to separate the effect of that kind of mimicking suicidal effect versus the other COVID effect for young ladies, maybe. It's
right.
What do you think? Yeah.
Right. Yeah. There's some how to say media report that the following suicide after the famous person committed suicide. Yes. Actually, yes. That might be important. We can analyze that data by adjusting, by controlling for the that effect kind of analysis. But I assume, I don't know, may not be a substantial effect of that. Yeah.
You think? Yeah. Okay.
But anyway, we can analyze that data.
So that was the one background I was told in Japan situation. But I think time is far behind our schedule. So I think we need to close today's lecture from here. And anyway, your lecture was so insightful for the researchers, especially young researchers in Korea. So I'd like to express my deepest thanks and acknowledgement for your excellent lecture, and hope to work with more Korean young researchers because of today's event. So may I ask you that if someone contact you, would you will be kind enough to respond?
Sure, sure.
Yeah,
I'm happy to communicate with the students and
yeah, right. I'm pretty sure. I know that you are the good person to answer all the small questions from the young researchers, especially. Okay. All right. Thank you very much. And with a big thanks to Korean side, I'd like to conclude today's lecture. Thanks a lot.
Okay. Thank you very much.
Thank you. Bye-bye.
Bye.